Let me jump to other topics in health policy for a minute. So 2013. This is kind of a big year, although it's kind of what do health reform. President Obama was reelected, so health reform is happening.
Yep.
What are your expectations for what's going to happen this year with it?
I think it's going to be still a lot of grandstanding in the House, and a lot of bills which are going to be put into place to try to slow things down. But the vast majority of things that are going to take place are just almost impossible, I think, to withdraw at this point. A lot of the regulations on how insurance has to be handled with lifetime limits and annual limits, that's just going to happen.
Yeah.
The Medicaid expansion will be a big deal. I mean, granted, this is 2014, but we'll be arguing about it all of 2013. But I still believe that in the majority of states, the Medicaid expansion is going to occur. It's going to be harder and harder to keep saying no, given that it costs really very little for the states, and a significant number of people will be affected. You're only going to tick off huge numbers of constituents if you deny them insurance that will basically be free to the state. And
I think, by the way, I am quite nervous.
Okay.
I should tell you, I'm quite nervous. And by the way, let me finish. I'll let you finish. Health insurance exchanges.
Well, that's the other thing. And here's again, I don't know where to come up with this. I'm sort of blown away by the fact that when the law was a bill, we all wanted. I shouldn't say we all wanted. Progressives all wanted one big national exchange. And the conservative senators sort of balked, and they demanded that all the exchanges be brought down to the state level so that we could have state level control and we could have local insurance and things like that. And that was a give towards conservatives. It just seems to me utterly ironic these days that it's the progressives who have embraced the local control so they can augment regulations, and the conservatives who've all basically abdicated responsibility and allowed everything to go back to the federal level. I'm not fearful of the sense that that's a big deal, because they were going to have to set up a national exchange anyway for the few states that were going to balk, and I don't think there's much problem with an economy of scale. It actually would probably be easier for insurance companies to deliver products to a national exchange for 30 states than it would be to try to deliver products to 30 different individual states.
Well,
So,
from your lips to God's ears, I
yeah,
must say I am really nervous about this, because I think it's the initial stage. We're going to have glitches all over the place. If I'm a governor, it seems to
right,
me there's two things that seem obvious. At some point, I've got to pick up the Medicaid, because otherwise I'm turning down huge amounts of money and I'm leaving huge
right,
numbers of people uninsured, and I'm also creating a monstrosity because I've got people with high enough incomes to get into the exchanges to get covered, and then I've got people who are too poor to be in the exchanges, and I
yeah,
tell them I have nothing for you. That sort of,
right,
there's a craziness to that. Uh,
yep,
on the exchange issue, though, it seems to me I totally want to punt the issue to the federal government. Let them start the thing. Let them screw it up for the first year or two,
sure,
and get everybody mad at all the bureaucratic junk that's going to happen because you're starting this new complicated thing. And if it's good, then I'll take it over later, because as a governor, I probably want to run the exchange in my state once it's working, because I want to
right,
tweak it to help my friends and that sort of
sure,
thing.
yep,
Make it work for my state would be sort of the nice way to say it too. But initially, the obvious play for these governors is to let the federal government do it and take the blame, and we have not set aside the kind of money and capacity to do this really hard thing. I think I don't think that people fully anticipated when the bill was passed just how many states were going to punt, and this is sort of creating a real challenge for can the government actually do this well?
So here's my response, which again, now we've left evidence into opinion. First of all, I can't imagine this is any less scarier than setting up Medicare was, or setting up Medicaid was back in the day. Those probably seemed incredibly daunting,
Yep.
huge opposition, the end of days, tyranny at our doorstep, and yet we've done all right. And 30, 40, 50 years later, it's American as apple pie, and it's being fought and held on to incredibly tightly by conservatives. So I think there was no way that doing any kind of massive insurance reform wasn't going to be scary and frightening and difficult. So I think that's the way it has to be. Um, I'm not terribly frightened by the number of states who are abdicating or releasing responsibility to the federal government. I think the difference between 3 and 30 is it's not as big a deal as many would think. A lot of this is going to be done over the internet or over phones. It wasn't going to be, I think, a lot of setting up offices. And so I think a lot of that is going to be okay. I also think it's important to remember that at this point, insurance companies want this to happen. They want the exchanges to work. They've redefined their business model. They have figured out all the ways that these things are going to do. This is how they're going to make money. There are millions of potential customers, many of them coming with federal subsidies. Mm-hmm. They want this to work. It's not in their best interest to watch this thing fall apart. They are massively resourced. And we're talking about, in the end, probably, millions, not tens of twenties of billions of dollars to set up and run an exchange. I don't think these are insurmountable numbers of money, and I think that there are enough interests that want to see this happen in business that they'll push it across the finish line. I think if they were fighting at this point all of the varied interests that would say that they didn't want this to happen, I'd be a lot more nervous. But in the end, the AMA is going to get behind this. It's the idea of they can have patients without insurance or they can have patients with insurance. They're going to fight for patients with insurance. Doctors want the Medicaid expansion. When they get beyond their politics and sort of the personal preference of I just don't like Democrats or I do like Republicans, whatever it is, a patient with Medicaid with significantly increased reimbursement rates, which are also happening, is far better than an uninsured patient. And with disproportionate hospital share patients going away, the hospitals want this to work. Yeah. Pharmaceutical companies want this to work.
By the way, the Medicare Medicaid history is really amazing. One thing is in Medicare, just how quickly it happened. Basically, a year later, boom. And by the way, they desegregated many hospitals across the South. Many of these hospitals said, "Oh, I'm sorry, there's just no way we could desegregate." And the Johnson administration said, "Oh, that's too bad because we can't pay you anymore for your elderly patients." And they all said, "Right, we desegregated on Tuesday."
Which is why I think that people will overcome their personal political preferences, doctors especially, and to get paid. It's like in the end they're gonna be like, "Well, turns out I love Medicaid because I want to get paid."
Now, Medicaid story was more complicated. It took about 7 years for all the states to come in, and Medicaid still, is filled with issues.
Well, Arizona didn't even come in until the 80s, didn't it? I mean, it took a long time.
Yeah, Arizona was a very weird case. But it took the states in the sort of former Confederacy about 7 years for all of them to really come in. And, but in the end, and it may be that President Obama has to leave office for some of these things to for a dignified path. It's interesting. I actually think that you see the difference, though, between the governors dealing with Obama, Republican governors, where they really do have a lot of common interest to make this work. And they have interest groups that want them to somehow find a dignified path to work together.
Yeah.
And versus Obama and the Republican House, where they really have very limited common interests in anything. And where it really is a kind of zero-sum game. I really don't know how those... let me say, I came into this knowing a lot about health policy and less about political science. And I must say that watching all this unfold, I wish I had come into it with a different balance, because it's obvious that our political institutions are where so many of these policy issues either live or die, and mostly die these days in terms of the quality of the product.
I say all the time, I wish I'd taken more political science in college. Well, there's a lot I wish I'd taken. Now, especially in doing what I do, it's a big difference. I think you bring up a good point, though. It's like we've been talking about things at the state level, like the exchanges and the Medicaid expansion, and those I'm reasonably optimistic about. The things that have to happen at the federal level and require the House, like IPAB, confirming the members, things that I'm far more pessimistic about. Unfortunately, that's all the cost control stuff, which is why I'm not nearly as optimistic that many of the cost control mechanisms that we have in place are going to work. I'm not terribly thrilled about the way I see ACOs rolling out. I've never believed that savings from electronic medical records are nearly what people believe they are. Yeah. I don't necessarily believe that preventive care is the silver bullet of money savings. I think it's a quality and outcomes good, but I don't necessarily know that it saves money in the aggregate as much.
There's a real chance that we just won't bend the cost curve for a long time.
And those things at the federal level, much less optimistic about them working. And because I think that the House is going to be much more of an impediment there.
One of the problems with IPAB is the perfect example, is the natural play for any politician is to rail against the deficit and to say we really have to cut the costs of Medicare, and then to oppose any specific thing that actually might do that, because anything that cuts costs tends to stop paying dollars to somebody that wants to get dollars.
Yeah.
or stop giving services to somebody who wants to get services, or in some other way constrain what we're doing, or that constrains the discretion of your House committee chair to sort of help the local wheelchair manufacturer or whoever who doesn't really particularly like the idea of competitive bidding for the product that they sell to Medicare right now.
Well,
So we're sort of dealing with all that kind of stuff.
I've written a number of times, and I think it's one of the things people just don't get, that it's not that we're spending $2.8 trillion and it gets burned up in the ether. That's entirely going into somebody's pocket. One man's waste is another man's income. And so, at the end of the day, it's not as if there are piles of money in a warehouse that are waste that we could just reclaim. That's what someone considers that their money and their income. And so cutting means you're taking money away from someone. And if you don't believe that anyone can take a pay cut or that someone deserves to make less, there's nothing to cut. And that is a real problem, because I think people imagine it's all in fraud, that there's like 3 or 4 really evil people out there who've sucked up $600 billion that we could easily trim from. But it's not. It's all in waste. When we say waste, we mean tests that probably don't need to be ordered, or drugs that we're paying too much for, or things like that. And all of those things are someone else's. They believe that's their money. They've earned it. And so it's incredibly hard to cut.
Yeah, and they're doing something that has some value.
Yes, absolutely.
Doing this test, it may be that on average it's wasteful, but it's
Correct.
not like I'm going and I'm stealing the money. I'm doing something that I believe is helpful for this patient, or maybe I'm not as critical of how helpful it is if I'm making some money from it, but I believe it's basically helpful. And
it is I think a lot of small incentives. I mean, I say all the time as well, like there's a reason 10-cent coupons exist, because they work. Small financial incentives drive people's behavior, and we have a very bizarre system that drives towards doing stuff. And doing stuff sometimes produces a marginally small good, but often doesn't, and it costs a ton. But it's not that first of all, it's not terribly easy to identify at a very large level. It's not easy to control and limit at a very large policy level. And no matter what, if you do, we just sort of have to accept that if you do 1 million tests, you're probably picking up some positive thing. So you have the anecdote, the powerful story, where somebody says, "Oh, well, getting those 14,000 extra tests saved my life."
Yeah,
I can't disprove the counterfeit. I don't know, but we just recognize in the aggregate, it's a complete waste of money. But that's very difficult to overcome those anecdotal stories.
Well, we have to. I think we should wrap up here, but I'll just say we have to come up with anecdotal stories that are emotional, vivid, and that push people in the direction of improved cost effectiveness of public policy. So that's your assignment for our next conversation.
I wish I was meeting with some fundraisers a week ago in one of our local foundations, and I was just saying, like, at the end of we have a Riley Children's Foundation, which sort of Riley Hospital, and every year they have a luncheon in December, and they always pick 10 champions, is what they call them. They're children who've had remarkable stories. And I jokingly say all the time, although it's serious, I do my year's share of public crying every year at this luncheon, because the stories are just stunning. Kids who've come back from cancer or horrible diseases, and it's amazing. There is nothing that exists like that in what we do. When I don't hit home runs, we're trying to hit singles every day. There are no... If I use an electronic medical record system and clinical decision support to pick up and prevent a woman from being abused, parading her on stage and saying, "Hey, she would have been abused without me," does not have the same emotional impact of, here's a child who had cancer, and look, we spent $10 million and look what we did. Or a NICU baby who grows. These are powerful anecdotal stories. I think sometimes in what we do, it's really hard to find the anecdotes in prevention, in public policy, in vaccines. We can't say, "Hey, this person might have gotten polio if we hadn't."
Can you think of anything more boring than saying, "Let's have a meeting to put fences around wells so that little kids never fall in them"?
And we're preventing. So we're just finding a normal kid and saying, "Hey, he might have fallen in a well."
Now, of course, once the kid falls in the well, then we'll spend $10 million to bring the crane to do,
absolutely,
we'll spend way more money on lung cancer research than we will on smoking cessation. Because what could be more boring than Ralph has a number to call where he can get a Nicoderm patch?
Right.
That's it's just, you're never going to sell papers that way.